Hello, 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 and welcome back for another, dare I say, amazing episode of the IBS Freedom Podcast. I mean, they're all amazing, to be clear. That's what I mean by that. But either case, welcome back. Amy now feels very daunted by what we have to produce in the next hour or so.
It's true. You set the bar very high all the time.
I did. And then what happens is I'm like the hype person and I get everybody super pumped for it. And then I immediately kick it to you for the first opening statement. So take it away, Amy. Wow, us, please.
And I do appreciate that because, I don't know, something about breaking the silence first is always hard for me. The intro, you seem to do much better at that. We're such a good balance. But yeah, we're talking about PPIs today. We're going to get into the juice of the PPIs. So I'm pumped about that. I think just to open up this conversation, I don't think either of us are anti-PPI. So Let's just throw that out there. But like so many things, they're misused and abused. And then it puts people into a predicament where they're having a ton of other issues because they've been on PPIs long-term or when they didn't need to be on them to begin with. So that's where the frustration comes in. It's not that PPIs are inherently evil or anything. There is a definite time and place, but I would say that if you're listening to this episode, try to listen to it through the lens of that most people that are on PPIs probably don't need to be on them. Or could find some other strategies to help mitigate some of the symptoms they're having versus taking the PPI. So yeah, that's kind of where I want to start the conversation, just so that we're all on the same page here. We're not anti-PPI, but dang, they get misused and abused. So yeah, that's my opening statement.
Yep. And that was a beautiful opening. I agree. If you were to look up top 10 prescription medications in the United States, either one or two of them are PPIs.
Oh, yeah.
The number one, pop quiz. Do you know what the number one most prescribed drug in America is?
Advil?
It won't surprise you when you hear it, but you might not think of it because we're not in this world. Lipitor, my friend.
Oh, yeah.
Lipitor.
That makes sense.
Everybody's got to be on that one. Woo, yeah. Good stuff.
Ooh-wee. Well, I actually, because, I've been researching this topic. Do
you care to say why? Are you at liberty to disclose?
Let's do it. I'm researching for a book. I'm writing a book. So that's the big reveal. I feel like it was very nonchalant as usual. But
you can do another reveal on your social media page and stuff. But yes, that was the official IBS Freedom Podcast reveal.
Yes, you've heard it here first.
I did a drum roll, though. You heard the drum roll, right?
That is very true.
Pretty legit.
But yeah, we're writing a book. We're slowly chipping away.
You are.
Well, yeah, I am. I'm writing a book. But yeah, I'm slowly chipping away at it. Yeah, and it's been fun. I feel like it's getting me back to my roots of blogging, which, I haven't really produced much written content recently because I'm so busy talking to you. But there's something really fun about taking pretty complex things and trying to create a really cohesive argument. So it'll be good. It's all about IBS. So everybody look forward to it. I think it'll probably be wrapping up if I keep cooking. Hopefully, I'll be finished writing the majority of it by somewhere in the summer. So stay tuned for that. It's in the works. Big things are in the works.
Yeah. I'm already excited to read it. So I call first dibs on reading when it comes out and getting an autographed copy for that matter. But yeah. So to your point, this has been super top of mind for you because as you've been fleshing out the book and writing material on this topic, you have been reading some research about PPIs specifically, right? So
yeah,
is there any particular study or research tidbit you want to share to kind of wet our whistle?
Well, just talking about how many people are on PPIs. So there was a survey of 3,500 people in Minnesota. And they were really just trying to discern who was using PPIs. So they just kind of took a general like pool of the population in Minnesota, 3,500 people, and 20%, so 1 in 5 were on a PPI. Isn't that crazy?
Wow. Well, and I guess I should have mentioned this before. So 1 or 2, it's like omeprazole and maybe Protonix. There are 1 or 2 PPIs that are in the top 10 or top 15 of prescription medicines. But then we also have Prilosec, which is over the counter. So you could also get this stuff over the counter, which is probably part of why, God, 20%?
Well, and even the study was a bit surprised, but they were saying too that because it's over the counter, it's really hard to determine how many people are on PPIs. But 1 in 5, how crazy is that?
Wow. Well, and then you think about the stats on IBS.
Right.
And maybe not coincidentally, irritable bowel syndrome affects 10, 15, sometimes 20% of any given population. So
yeah, and they talk a little bit about this too, because there was the question of, are these things independent? Like, do people that have IBS just naturally have GERD too, independent of PPIs? But what they found was a strong link between like IBS symptoms and PPIs independent of GERD or other gut disorders. So, it's very interesting that
the plot thickens.
There seems to be a link between like the use of PPIs and IBS, regardless of like other symptoms, essentially.
Well, and that doesn't surprise me a bit because we just came off the heels of a whole hour-long discussion about low stomach acid, right? When you have low stomach acid, either because of stuff going on in your body, stress, nutrition, etc., or because of acid suppression with PPIs, things get weird.
Yeah.
There's no other way to put it.
Yeah, and we could talk too all about the ramifications of PPIs gut-wise, which we will do. But even outside of the gut, there's so many reasons not to be on PPIs, just from a nutrition standpoint. If you're on... Go ahead.
Sorry, can I interrupt you for a quick second? We are acknowledging, though, some of you probably feel like you're stuck between a rock and a hard place because you don't want to be on these medications, but you don't know how to get off, or you feel like you're going to have a rebound if you get off. So we're going to kind of get to that, but this is more for the people who really just don't know. And they're like, well, gosh, golly, gee, why can't I just take my Prilosec and be done with it? So that being said, I didn't want to lose people because we almost sound like we're waving a finger and saying, you shouldn't be on these, you silly gooses.
Yeah. No,
that's not at all what we're saying.
No, correct. I think where I'm coming from is having zero off-ramp. So, we tend to work with people who have been on PPIs, whether they're on them when they start working with us or whether they're off them. I've worked with a lot of people on how to get them off PPIs. Like I said, there's a total time and place. Sometimes I've suggested for certain patients that maybe it makes sense for them to take a PPI. And maybe they're fighting it. So I'm a proponent of PPIs in those situations. So, I think where I really get a little squirrely in particular is when doctors are like, get on this Protonix and you're just going to be on it forever. And it's like, problem solved. And,
yep. And another day at work.
Right. And there's so many like long-term risks to be on PPIs long-term like that. You have to weigh the pros and cons of any intervention you do. And, you'll have people with maybe like some reflux or just kind of some stuff that's definitely bothering them that probably could be influenced by diet and lifestyle primarily. Now, maybe you still need some other supports, which, you know, I've helped clients implement other supports, but really it's the extended periods of time on these drugs that are really problematic, I think, for some of the long-term issues that can develop, like nutrient deficiencies. You know, these drugs were meant to be used short-term, but they've just kind of become long-term things. And we can talk about all the reasons why that is, because there's some physiological changes that happen when you're on the PPI that make it harder to get off. We're going to talk about that. But yeah, I mean, just thinking of the nutrient deficiencies that can arise from PPIs, I think there's an increase in infections. Gut-wise, I mean, this is wild. The increase in C. diff infections with PPIs is a big one, which is a super serious gut infection. Depending on what studies you look at, I mean, there's a pretty high, I mean, compared, it's not that you would necessarily die if you got C. diff, but it's a pretty high mortality rate per the infection.
And it could be hard to get rid of.
Right. It's super horrible if you have a bad recurrent case of C. diff. But again, in the worst cases, it can kill you, which is terrible. But, you know, serious gut infection that you do not want. There seems to be increased incidence of that with some of these drugs.
Can I pause you?
Yeah.
Sorry, because I think that the C. diff thing is very interesting. And I think that it's kind of a downstream symptom of something else that I want to point out.
Yeah.
So in the low stomach acid episode, we talked about how stomach acidity, or just like pH in general, is one of the main ways that you can influence what critters grow and what critters don't. So if we were in a microbiology lab right now and we had Petri dishes and we were studying how we could get a type of bacteria or yeast to grow, there are only so many things that we could alter in that Petri dish. We could change the food that it's given or the growing medium. We could change the pH of the growing medium, which is kind of what we're getting at right now. Or we could change whether or not that microbe is exposed to oxygen, and if so, how much. Those are the three main ways that you alter what lives and what dies on a Petri dish. And we are just walking Petri dishes at the end of the day. So stomach acidity and its downstream consequences or influence on things like bile and pancreatic enzyme secretion is really going to alter the terrain in not only the small intestine, but maybe as far down as the colon, which is what you're starting to get at. And you know, if you look at how C. diff normally occurs, it's from overuse of antibiotics, right? Well, so what happens is normally a lot of us are carriers for C. diff, but the rest of our good microbes and the diversity of our microbiota is such that it puts the kibosh on the C. diff and it never gets a chance to get squirrely and weird. But if we lose that inhibition, if we lose that brake pedal on the C. diff, because we kill off all of our good guys and the microbiota becomes less diverse and less stable and less healthy, that's when C. diff gets to come out and play. And so to me, when I hear that PPIs increase the risk of C. diff infection, to me, that's translating automatically to it alters the microbiota in a way that is not good, and it's probably reducing diversity and reducing the growth of good bacteria and maybe allowing for the growth of other opportunistic pathogens. If we could grow a crop of C. diff more easily with PPI use, who's to say we couldn't grow a nice crop of E. coli or Klebsiella or Pseudomonas or something like that too?
Right. And again, there's, like you said, there's definitely research that PPIs or that PPI use is associated with dysbiosis in the small intestines. There's also some studies on stool sample studies, where they're showing significantly lower levels of diversity, just like you're talking about, compared to non-users. And they also found higher levels of pathogenic E. coli, as well as, again, higher incidences of C. diff too. But Yeah, it's C. diff infection. So it is, again, those things aren't necessarily great. And again, it's not to say everything that you do could have potential risk. And so sometimes, you could weigh all the pros and cons and it still makes sense to take the PPI, but it's good to have like a discussion around, it's good to be cautious around PPIs is essentially what I'm trying to say versus to totally demonize them. Because again, there are these microbiome risks, there's nutrient deficiency risk. But yeah, I like that you broke it down, how you're breaking it down and saying, here's the diversity changes and the microbial changes that are downstream are really problematic, because that's what's showing up in the research heavily.
Yeah, like the mechanistic view, I guess.
Yeah.
And I'll throw this out there too. There's a study that I'm pretty sure we've talked about before. I've referenced it a lot in my material before, like in FODMAP Freedom. But there's a study, I can grab the reference in a minute, but it's titled something to the effect of, is it useful to administer probiotic with PPI in children with GERD? And it's like a randomized placebo-controlled trial. Mm-hmm. And what they did was they had a group of children who received PPIs. They had one group that received PPI with the placebo, and one group got PPI plus basically Biogaia gastris, that strain of probiotic. Mm-hmm. And then they had a control group that they just observed. They didn't get PPI or anything. And what they found was the incidence of SIBO after, I believe it was 3 months on the PPI, the incidence of SIBO was crazy high in the group that received PPI plus placebo. It was something like 36 out of 60 of the kids developed SIBO based on breath testing, which is intrinsically flawed, but nonetheless, we're going to take it for what it is, versus I think it was maybe like 4 of the kids out of 60 in the probiotic cohort. And the control group didn't change at all. So pretty wild stuff. And again, it goes back to this idea, one of many reasons why PPIs can be deleterious is that they are causing a microbiota shift and they're resulting in a lack of good bacteria, a lack of diversity, maybe the overgrowth of bad boogeyman pathogens. And probiotics are one of several tools that can help inhibit the growth of pathogens and kind of replace, but not really replace, your good guys that you're losing. So it makes a lot of sense mechanistically why a probiotic would show promise in this group that received PPIs.
Yeah, no, that's super fascinating. It makes sense. It's really funny. There's a couple other interesting studies that would go well with that are kind of fascinating. So there's one survey, again, this was a large survey where they, semi-large, it's 1,700 patients, but they're talking mainly with their doctors. So they're monitoring each of these patients from the doctor's perspective. So I think the doctor was giving them like surveys and things like that. But this study's interesting because it's trying to determine how many of these like almost lower GI symptoms are present pre-PPI or after PPI. So, we've definitely worked with people where they take a PPI and they have struggled post-PPI or can definitely link the PPI to some of their bloating, distension, gas, pain. They can link the PPI to some of these more IBS type symptoms. So this study was really interesting because there were definitely people that had those symptoms pre-PPI. So, the PPI seemed to double the amount of people that had symptoms like bloating, abdominal pain, abdominal discomfort, and gas.
Pretty significant.
And another interesting tidbit, which again, like speaks to the microbial shift, is that irregular bowel movements, increased frequency, and frequent diarrhea appeared to be more common after treatment with PPIs, while hard stool and frequent constipation were more common before the PPIs. So there did seem to be, again, to like a little bit more of a constipated slant before treatment and more of like a diarrhea slant after treatment, which was kind of interesting. But this is another thing that they monitored. So they monitored what the doctors did with the increase in IBS symptoms. Like, how did the doctor manage?
Either nothing or they gave him a low FODMAP handout, right?
Well, I can't remember all the interventions, but the intervention that was the most helpful was antibiotics, was rifaximin, essentially. How wild is that? Which, again, is probably not the best intervention. Like you said, maybe probiotics would work, but it is really telling because it's showing that it's affecting the microbiome. So, it's really interesting. It seemed that the rifaximin played a role in reducing the PPI-induced symptoms.
Which makes complete and total sense.
Right.
I similarly would love to see a study where they use prebiotics.
Yeah.
Maybe administer PPI plus guar gum, like PHGG or psyllium or something, and administer that and do kind of like the study with the children and have one arm that receives PPI plus placebo, one arm that receives PPI plus prebiotic, and one arm that is just a control group. I think that would be an interesting one too. As a side note, before I forget though, I did find that paper, and the PubMed ID, if anybody wants to check it out, is 29291607. So well done study, well designed, and the results were pretty profound. But I think that a lot of the normal stuff that would treat dysbiosis would probably help mitigate issues from a PPI.
Right.
It's just a matter of how many we've actually researched at this point.
Right. In the conventional realm, that's typically, the weird thing is antibiotics could potentially help some people with dysbiosis and not others. But it's interesting that the rifaximin helped a bit. But you'd have to imagine that probiotics have been shown to help with the kid study, at least for preventing SIBO, based on the breath testing. But yeah, it's fascinating. And I think, like, to sum it all up, it's all microbiome changes, like we've been saying. Like, it's sorry, I feel like I've interrupted you a bunch.
No, you're fine. I have another hypothesis to noodle on, and I don't know if this has been researched.
I wonder
if PPIs can cause candida overgrowth. Right? Because if we're saying that PPIs reduce diversity and reduce the good guys and allow bad boogeymen to grow, that probably would include candida, because it's kind of having a quasi-antibiotic-like effect in a way. So to me, that translates to maybe some candida overgrowth could be rooted in PPI use as well. And we have 20% of the population taking these things. Oh my gosh.
I know. Isn't that wild? I was like, holy moly. That's crazy. But yeah, it's, and I think if we're moving more into the realm of like, if you're experiencing, because I think we could talk about, if you're considering them or if you're on them, maybe we talk about, okay, if you're on them.
I think, let's speak to those people because like I said, I think a lot of people listening to this episode probably are already on them and they already know why they're bad and they're freaking the F out trying to get off of them, but they haven't been able to yet.
Yeah. Well, and it brings me to a client, who, I'm working with, who it was really interesting. So I feel like he took maybe, or he started developing some silent reflux, like a lot of coughing, kind of mucus, like weird sensations in the throat that they determined was silent reflux. So he was prescribed a PPI that took over all those symptoms. But like 3 weeks later, he got all these nasty, lower GI symptoms started to come out of the woodwork. So a lot of visceral hypersensitivity, a lot of gas, just a lot more IBS-like symptoms. So then it seemed like his GI doc was on like a wild goose chase, like whack-a-mole. And to his credit, he was like trying. I just feel like his the GI doc's hands or skills are limited in terms of the conventional model that they're operating in. But, you know, diagnosing with SIBO, diagnosing with all these things, like trying rifaximin. And like, to me, it seemed like there was a very clear connection with the PPI started, and then like 3 weeks later, all these other symptoms came up. But we're kind of going down the rabbit hole. And it's a tricky situation because, you know, we've been kind of weaning off the PPI, and a lot of the lower symptoms are like way better, but some of that refluxy type symptoms is coming back. So and we're trying different things. And again, it's so tricky, and we could kind of speak to why it's so tricky to get off some of these drugs. I know you were kind of wanting to talk about the parietal cells, so maybe you can kind of jump in there. But yeah, like, it's not easy.
Well, it's not always easy.
Yeah.
There are those freaky people who just decide to stop the PPI, and they do it. And you find out afterwards, like, you stopped your PPI cold turkey. Oh my God.
Right.
So I have had those people where, you know, I kind of counsel them, don't go off cold turkey. Here's what you do. And they just say, screw it. And they go off of it anyway. But for a lot of people, it can be difficult. And that's because, as you alluded to, the body is so much smarter than we are.
Right.
That's what it comes down to. So your body knows that you need stomach acid and is trying to produce acid for you. When we suppress stomach acid production and we suppress the proton pump, your body's natural response is, oh shit, we need more stomach acid. And it's really hard to make it right now. Our acidity is not, our pH is not correct. We'd better double our efforts and try harder. And so what happens is, this is not exactly the same thing, but it paints a picture, especially because you have a toddler. There was some post I saw on social media years ago that was like, oh, you want to slow your toddler down, put some weight on their ankles, like get weighted straps that people use for exercise. And then somebody else commented, was like, no, don't do this, because then you're going to have a really buff baby and then you're never going to catch them. And it kind of reminds me of that. It's like you had the shackles or the weights on the parietal cells for so long, and it didn't actually turn them off. All it did was it made big, beefy parietal cells. So you get this hypertrophy, this growth of the parietal cells. And now when you come off of the PPI, you're not just going back to your baseline from before. You actually have these like Arnold Schwarzenegger, super strong, beefy, capable parietal cells. And when you take the brake off of them, they're like, woo! And they make way more acid than ever before.
Yeah.
And you get this rebound hyperacidity. It's not just, oh, I felt good on the PPI and now I'm returning back to my crappy old baseline. It's actually can be quite severe.
Yeah, so, you have Hulk baby parietal cells.
Exactly. Again, you've got these little Arnold Schwarzenegger cells in your stomach, and they're just so happy to help you out and make you all the stomach acid on planet Earth, because they know damn well you've been deficient in stomach acid for a long time.
Yeah.
But that rebound hyperacidity can not only suck really bad, it could be dangerous potentially if it's bad enough. So acknowledging first, neither of us are prescribers.
Right.
Amy's a registered dietitian. I'm a freaking chiropractor. Keep that in mind. We do not have prescriptive authority. It is out of our scope of practice to tell you how to go off of a drug.
Yes. ...
However, here is just like my opinion as a gut expert person with no prescriptive authority. Here's what I have counseled people on. First and foremost, loop in your prescriber. Some of them might not be open-minded to this. They're going to roll their eyes at you or be like, oh, whatever. But in theory, you should talk with your prescriber. 1. Number 2, don't go off cold turkey. There are people who get away with that, but it's not everybody. And it can be really awful to get rebound hyperacidity. So wean down slowly and pay attention to your symptoms. I think a pretty standard dose of a PPI for most people is 20 milligrams. I have seen people all the way up at 80 before. So if you're up higher, 40, 60, 80, you would just do a modified version of this. But what I usually have people do when they're at 20 is I have people go down by like maybe 25%. So if it's like a tablet or a capsule, maybe you could cut it with a pill cutter. But if you could go from like 20 down to 15, for example, and you stay there for maybe a week or two and you see how you do. If you get to a point where you kind of stabilize and you feel like you're okay at that dose and you don't have a lot of additional symptoms, then you could progress down the next step. So maybe you would go from 15 down to 10. And again, you're going to stay at that level until you're stable, you feel good, you don't have a lot of additional symptoms, and you keep stepping it down. So again, the progression I've had people do before, again, acknowledging they're talking to their doctor and making sure it's okay. I've had people go from 20 down to 15, down to 10, down to 5. And then after that, it's really hard to cut the pill any more than that. And then they just go off from 5, typically. Again, some people might stay at each stage for only a week or two. Some people might stay at each stage for several months. It really depends on the person. But then as you do that, you can layer in things to treat the symptoms of the GERD or the silent reflux or the gastritis or whatever. One example, well, first of all, we recently did an episode with Molly Pelletier. And so I think that episode posted in October, maybe. I forget now. September,
yeah,
October.
Sounds right.
But we just recently talked with Molly Pelletier again. So check that out. Check her stuff out. She's on Instagram. She's on YouTube. She talks a lot about GERD and gastritis more than we do. So check her stuff out. But also one free, easy enough thing to do. There was a meta-analysis a couple years ago that showed that deep breathing exercises can be helpful for GERD. And one of the reasons they said it probably is helpful, or one of the probable reasons why it's helpful, is because it tones and tightens up that lower esophageal sphincter. Mm-hmm. So the sphincter that separates the esophagus from the stomach and prevents the stomach acid from going up the tube, we could tone the lower esophageal sphincter with deep breathing, particularly like deep diaphragmatic belly breathing is wonderful for this. If you could really commit yourself to doing 5 or 10 minutes of deep belly breathing, 2 or 3 times a day, I think that would be wonderful. For those of you who like to fact check, the PubMed ID for that study, the meta-analysis I mentioned, is 322-33626. So that's the proof, if you will. But you could be layering in herbs like slippery elm and marshmallow and aloe and DGL, and you could be doing the mindful eating stuff, and you could be doing the deep breathing or yoga, working on stress, working on sleep. Like you could be doing all of those things, maybe reducing some acidic foods from your diet for a short period of time while you're reducing the PPI. But it can be a long journey for some people, depending how much your parietal cells beefed up on you when you were on the PPI.
Now all I keep seeing in my head is like a Hulk toddler parietal cell.
I know.
But yeah.
I know. You know what I'm thinking of, actually? I'm going to date myself probably because I'm a little older than you. Are you familiar at all with strong bad emails? Have I ever sent you one of those? I feel like
you did. I feel like you definitely have.
There was one. So the elder millennials in the room will appreciate this. So there's one, and I'll send it to you again just to educate you, youngling. Mm-hmm. But there was one where he teaches one of the other characters to draw a dragon. And the way he draws the dragon is so stupid, but he's got this like beefy arm coming out the back of his neck for some reason. And so I'm picturing like a Trogdor-esque situation. It's this dragon with the big beefy arm coming out the back of his neck. I'm kind of picturing that version of a parietal cell, but also blended with a toddler.
Right.
It's a very confusing image, honestly.
Oh my gosh. Well.
Oh my God. New idea. Pause. Right here. Okay. People. I don't know what the prize will be yet, but let's have an art competition for our viewers.
Oh my gosh.
Tag us in Instagram. Tag Amy, who is...
Amy _Hollenkamp_RD.
Yep. And I'm gut.microbiome.queen on Instagram. Tag both of us and use the hashtag IBS Freedom Art Contest. Draw us a beefy looking toddler, hulked out Arnold Schwarzenegger arm toddler parietal cell. There will be a prize. I don't know what it will be yet. Maybe like you could be a guest on the podcast or get a session with us or something. But I want to see your art
come
ASAP.
to life.
Please and thank you. So,
Yes.
Okay, now back to academic stuff. That was very important.
I can't wait for like us to forget that you did this,
I know.
and then in like a month or something when this gets released, us to just get a flood of hashtag.
I hope we do.
I know,
I hope
that'd be
that people
fun.
don't just shrug it off and ignore it. I hope that people really take me up on this art thing.
We have to share it if we get multiple entries.
sure.
Like maybe voting on the winner. How fun would that be?
Ooh, yeah, that could be good.
Yeah.
Stay tuned, people. This could be a fun little November treat for all of us.
Right. I don't even know where we were now.
I don't know either, but now I'm thinking, well, I think that we need to participate though.
Okay,
We should draw something and post it also. So now I need to get out, the old colored pencils and
Right.
whatnot and draw my Trogdor baby parietal cell.
Okay, yeah, I'm into it. I'll see what I can do. But yeah, I mean, the weaning can be tricky for sure. I weaned off PPIs, and this was like back in the day. I was on PPIs because I had gastritis.
I don't know if I ever knew you took PPIs. Did I
Yeah.
know this? Really?
Yeah, I took them between my freshman and sophomore year of college.
Oh, so this predates the SIBO journey.
Yep.
Ah.
And I took them for probably about 3 to 4 months. And I took them in combination with sulcrafate. I never know how to pronounce that, but
You were correct.
kind of coats the stomach. So I took them in combination with that. And I don't necessarily think I was on like a super intense dose, but I had gastritis. So I was having some pain, some stomach pain that was gastritis. And like, I feel like it just didn't really help. Like there was not really any symptom reduction or anything with my PPI experience. Now, again, I've had some clients who've really benefited from a period of PPI use, but for me, it didn't really resolve symptoms at all. So eventually I was just like, I'm going to come off this. Like I'm fine, I guess. So I went off, and it definitely was tricky. I feel like the wean was weird. I definitely had a little bit of reflux. I don't think it was anything insane for me. And I was young. I feel like I could kind of like bounce back pretty well, but it was definitely not a fun experience to come off PPIs. But yeah, the wean is just, it's tricky. It's like one of those things where we definitely, like, if someone's considering it, make sure that you need to go on them, because the wean can be a little bit rough, and there could be other interventions that would suffice to help a lot of your symptoms. But then on the other side, like, I know that there's been lots of my clients that have been able to successfully wean. So like, it can be done. It's not necessarily always easy, but stick with it. Go as slow as you need to go. Loop your doctor in if you're feeling like you're struggling, or if they can think of any kind of
Probably legally we have to tell them to loop their doctor in regardless.
Yeah, for sure. Definitely. Well, again, like I've seen some clients where like they've told their doctor, and their doctor's like, okay, like it's like there's that.
Well, that's
so
the thing. They're not going to be helpful, to be clear.
Right.
But you have to tell them about it anyway.
Right.
Is what we're saying.
For sure. So loop your doctor in. There have been some doctors that have been more helpful than others. So like with me, I'll usually say like, why don't you ask your doctor, like if you're going to do this wean, why don't you ask your doctor like what they would suggest weaning? So I've done that before, and that usually like their doctor essentially has to at least instruct them them on how they would wean. That's
sometimes you can switch medications at the end of a wean too. So again, if you started off at like 20 milligrams of omeprazole, you could go from 20 to 15 to 10 to 5 to 0. I feel like it's kind of like having kids. The transition from nothing to something is probably the trickiest. Like going from no kids to kids period is the trickiest transition. So likewise, going from some dose of PPI to no dose of PPI is probably the hardest step for a lot of people. And you could cushion that a bit if you transition from the PPI to like an H2 blocker or some Tums or like an alginate supplement. I think Life Extension has one called Esophageal Guardian, maybe. So you don't have to go from something to nothing right away. Because again, PPIs are pretty intense. You could step down to something a bit less aggressive and something that's not going to beef up your parietal cells at least.
Right. Those beefy parietal cells.
Beefy Trogdor parietal cells.
But yeah, and again, I think that herbs can be really helpful, like you said. So yeah, you're definitely not doomed if you're on a PPI, which again is like not the message we want to send during this podcast. But I think again, like to me, there's a lot of hope because I've seen a lot of people who've come off PPIs and like a lot of their lower GI symptoms like resolve much more easily. Again, if you're trying to do, which again maybe is a little bit of a different side topic, but if you're doing all this work for like IBS and SIBO and you're on a PPI, it might make a lot more sense to try to work off the PPI before getting super intense with like the IBS SIBO stuff, because it's going to affect everything downstream. So like I've seen that where people are kind of on a PPI and desperately trying to get like kind of their lower gut sorted out. And it might make sense to sort of like parcel off, well, how can I potentially get off this PPI? Might be a better first step.
Yeah.
Than immediately going to like treating SIBO and staying on your PPI.
Antimicrobials, rifaximin.
Right.
Yeah.
Right.
Yeah. I think that any of those other efforts to treat the downstream consequences, at the bare minimum, they're going to be less effective. Worst case scenario, they're not going to be effective at all. And it's going to be a total waste of time, effort, and money until you get the kingpin, so to speak. So, yeah. But, I think that a good thing to say now towards the end of the episode is reiterating the idea that probably most medications do have a time and a place. I don't think these medications should be in the top 10 prescribed medications in the United States. I don't even think they should be in the top 50, probably. Like these should be for very specific scenarios occasionally and with great caution and only for a short period of time. But for a year now, I don't know what to say. But one great example is ulcers. Particularly if it's a bad enough ulcer, you probably do legitimately need a PPI for that. Right. And I've shared this before, but I'll share it again. My mom had what they called a geyser of an ulcer that sent her to the ER. She basically almost bled out in the course of a couple of hours. It happened to be right over one of the major arteries in either her stomach or her duodenum. I forget. But she burned a hole in her stomach at just the perfect location, and she lost a lot of blood really rapidly. And, her hemoglobin dropped down to like 6. She had to get blood. She was in the ER for a long time. She had to be hospitalized for a while. So that's a really good, really extreme situation where when the doctors put her on a high dose, like 80 milligrams of omeprazole, I was not going to argue to that. I thought that was totally appropriate and life-saving and rational. The problem is they pretty much explicitly told her, yeah, you're just going to be on this now. And there was no off-ramp, no discussion of risk-benefit, no discussion of what it's going to do to her gut, no discussion of nutrient deficiencies, which is very concerning because she's had a Roux-en-Y gastric bypass. And she doesn't absorb things well to begin with, let alone if you put her on a PPI for the rest of her days. What ended up being more of the case is we found out, so A, I love my mother to pieces, but she does not manage her stress well at all. So that's a big significant factor, and her work was really getting to her at that time in her life. But also, she was kind of band-aiding some stuff and being a silly goose, and she was taking Excedrin migraine. Now, that might not be concerning for normal people, but again, she's had a Roux-en-Y gastric bypass, and she's not allowed to take NSAIDs. And Excedrin migraine is an NSAID. Well, she didn't know it. You know, when they taught her after the bypass, when they taught her about NSAIDs, they said, you know, Aleve, Advil, ibuprofen. She didn't think Excedrin migraine was in that category. So she was taking Excedrin migraine every so often for headaches. And I think she might have been drinking coffee again at that point and maybe some wine. There was like multiple factors and a lot of stress. And she kept going until her body said, screw you, lady. We're going to get your attention now, by God. And, you know, again, I think it was totally appropriate for her to be on a high dose of PPIs for a couple of months. But after maybe a period of 2 months, I started kind of coaching her on the wean down process. At the time, one of the things that was really helpful for her that I don't think we mentioned with Molly recently, there's a supplement from Biotics Research that I've used with gastritis and the sort of stuff before with good success. It's called Gastrozyme. So gastra, like gastric, zyme, Z-Y-M-E. They're these little tablety looking things, and you can swallow them whole. Or if you want them to coat the esophagus a little bit more, you can chew them. They taste terrible, but you can chew them. And I had her taking a lot of Gastrozyme at one point, and we did successfully get her off the PPI, and she hasn't been on it for 8 years. Because actually, I think my daughter was about 2 months old. I vividly remember I brought my pump with me to the hospital when I was there with her. And I remember her telling me, go home, you have to go home. You have a 2-month-old. You have to go home to her, and kind of shooing me out of the ER. But yeah.
Oh my God.
There are cases like ulcers where it's entirely appropriate to be on these medications for a short period of time. But maybe if you took a probiotic or a prebiotic or dialed in your nutrition at the same time, maybe you could mitigate the potential risk when you do have to take it.
Right.
I feel like...
Couldn't say it better.
Yeah, I think that was probably the end of the shtick. So, guys, you now have an assignment. You got it. So remember, you are going to be drawing a beefy parietal cell baby. No, toddler. I'm sorry. A beefy parietal. This is hard to say. A beefy parietal cell toddler with big beefy Trogdor / Arnold Schwarzenegger / the Hulk arms. And you're going to put that on Instagram with the hashtag IBS Freedom. What was, crap, I forget now. IBS Freedom Art Contest, drawing contest. Gosh darn it. I think art contest is what I said. And you're going to tag me at gut.microbiome.queen. And you're going to tag Amy at Amy_Hollenkamp_RD. Correct. And we or the collective hive mind on Instagram are going to judge the art, and we will come up with some sort of fun prize for the person with the awesomest drawing. By the way, I don't think we should base this on skill level. Not everybody's artistic. So we might pick the favorite based on how amusing it is, or how beautiful it is, or how unbeautiful it is. We will find out when we get there, but go participate in our first ever IBS Freedom Podcast art contest, and we will see you in the next episode.